Handling of autism and Asperger's syndrome in Latin American republics. Autism spectrum disorder, including what was previously termed Asperger's syndrome, was not formally recognized until the mid-20th century globally, with diagnoses by Leo Kanner in 1943 and Hans Asperger in 1944. In Latin America, adoption of these concepts lagged due to limited medical infrastructure, colonial legacies, and socioeconomic disparities. Prior to formal recognition, neurodivergent traits, such as social withdrawal, repetitive behaviors, or sensory sensitivities, were often lumped under categories like madness, idiocy, or intellectual disabilities, interpreted through cultural, religious, and emerging scientific lenses. Handling varied by country, class, and ethnicity, with indigenous and rural populations often relying on family or traditional healers, while urban elites accessed nascent psychiatric institutions influenced by European models. This response covers Mexico, Argentina, Uruguay, Brazil, Bolivia, Venezuela, and broader Central and South American contexts across the 19th century, 20th century, and today. Evidence is drawn from historical, anthropological, and public health sources, noting that records are incomplete due to oral traditions, colonization, and under-research in the region. 19th century, pre-diagnosis era, and treatment of mental disabilities. In the 19th century, autism-like traits were not distinguished as a specific condition, but treated as part of broader mental or intellectual disabilities. Latin American republics, newly independent from Spain and Portugal, inherited colonial attitudes pathologizing differences as moral failings or divine punishments, blended with emerging European psychiatric influences like moral treatment. Resources were scarce, with high prevalence of untreated mental disorders amid poverty, epidemics, and social upheaval. Treatment often involved family care, traditional remedies, or confinement in rudimentary asylums where available. Mexico, post-independence mental health care was limited to charitable institutions like the Hospital de San Hipólito. Disabilities were managed through moral treatment or isolation, with Porphyrian-era reforms introducing European psychiatry, but access was urban and elite-focused. Neurodivergent individuals from lower classes were often marginalized or cared for at home. Argentina, after independence, Buenos Aires established asylums like the Hospicio de las Mercedes, influenced by French models. Mental disabilities were treated with seclusion and labor therapy, but stigma led to family concealment. Brazil, independent in 1822, Brazil's Hospicio Pedro II in Rio de Janeiro adopted moral treatment, but racial prejudices rooted in slavery framed disabilities as degeneration, precursors to 20th century eugenics. Uruguay, Bolivia, Venezuela. In Uruguay, mental care was rudimentary, relying on family or church institutions. Bolivia and Venezuela had minimal infrastructure. Indigenous groups like the Aymara or Guarani integrated differences via communal roles, but colonial legacies stigmatized them as savagery. Central America followed similar patterns, with family-based care amid political instability. Overall, the century saw precursors to eugenics, with 19th century racial science in Brazil and Argentina viewing disabilities as hereditary flaws, setting the stage for exclusionary policies. Disparities were stark. Elites accessed emerging psychiatry while rural, indigenous, and poor populations faced neglect or exploitation. 20th century, emergence of diagnosis and persistent treatment gaps. Autism diagnosis reached Latin America unevenly in the mid to late 20th century, often delayed by resource shortages and cultural stigma. Early handling mirrored global shifts from institutionalization to community care, but eugenics influenced early policies, associating neurodivergence with racial inferiority. By the 1980s-1990s, ASD was more recognized, but diagnosis ages averaged school entry, with Latinos diagnosed later than non-Latinos due to barriers like cost and awareness. Treatment included behavioral therapies, but access was limited with wide treatment gaps, only 1 in 5 receiving care. Psychiatric beds decreased as deinstitutionalization spread, but community services lagged. Mexico psychiatry leagues formed in 1936, autism awareness grew post-1980s, but prevalence studies showed underdiagnosis. Handling involved asylums like La Castaneda early on, shifting to family care amid stigma. Eugenics targeted degenerate groups. Argentina, anti-psychiatry movements emerged in the 1960s, 1970s. Users' movements by the 1980s advocated rights. Autism media coverage increased but stereotypical. Eugenics focused on immigration exclusion. Brazil, early eugenics promoted sterilization for disabilities, Autism diagnosis delayed, with cultural views seeing it as a white disorder. Mid-century shifts to behavioral interventions. Uruguay, Bolivia, Venezuela. Uruguay and Bolivia had fragmented services. Venezuela's coverage was stereotypical. Central America saw late diagnosis. Overall, barriers included costs and long waits. Eugenics waned post-W2 but left legacies of marginalization, with neurodivergent individuals often institutionalized or unsupported. Today, policies, treatments, and ongoing challenges. Most Latin American countries have ratified the UN Convention on the Rights of Persons with Disabilities, promoting inclusion. However, implementation varies, with low mental health spending, underdiagnosis, and stigma rooted in machismo and colonization. Treatments include ABA, speech therapy, and medication, but only minorities access them. Adults receive even less. Disinformation is rife in Argentina, Mexico, and Venezuela. COVID-19 exacerbated issues via fragmented systems. Despite progress, ongoing disparities and colonial legacies continue to shape the experiences of autistic individuals and their families in Latin America, highlighting the need for culturally attuned, equitable approaches.